right. So it's my honor to introduce our next speaker, Professor Feifei Zhou from Peking University Third Hospital. He's a professor of orthopedic surgery there and also the co-chief of the spine service. Feifei has been very involved in CSRS AP and is one of the emerging leaders in the Asia Pacific area in the cervical spine space. So he will present to us the Peking University Third Hospital classification surgical strategies for congenital cervical scoliosis.
Okay, thank you, Chen, and it's my great honor to be here, to be invited to join this wonderful course. So before my presentation about our work on the congenital cervical scoliosis, please let me introduce some of I have nothing to disclose, and I will give you a brief introduction about our department. So the Department of Orthopaedics in Peking University Third Hospital was established in 1958, the same age of our hospital. And I must to introduce the first chairman of our department, the founder of our department, Professor Yang. He was a legend, and he trained as a chief resident in Johns Hopkins Hospital and came back to China in 1944. So he performed the anterior cervical discectomy infusion in China in the early 1960s. So the structure of our department was a whole part of orthopedic surgery and divided into three parts: spine, adult reconstruction, and trauma. So the spine team is the largest in our department. We have more than 10,000 spine surgeries per year, and we have the highly recognition in our country. And we divided our spine team into 5 subgroups. So we divided the C0 to C2 of upper cervical spine group, and our group from C3 to T1, lower cervical spine. And we also have the thoracolumbar spine team, the tumor team, and the deformity team. So you can see a big family picture of our department. We have 276 beds and more than 70 surgeons and more than 120 nurses. So we have a high efficiency. We performed more than 1,600 surgeries per year for the whole department. And it's a busy hospital. We served more than 20,000 people from the outpatient clinic and ER. So our department have a traditional of the global communication because our department is the first AO spine reference center in China in the early 1901. And you can see our chairman now, Professor Li, is the current chairman of AO Spine China Council. And Professor Sun just at the past president of CSRS AP. And also we have a connection with some very famous hospital in the US States, for example, the HSS and also the Mass General Hospital. And you can see Dr. Li Tan was one of the international fellowship in 2019 from the CSR Traveling Fellowship in our hospital. And we got the reunion this year in the CSR's AP meeting in Korea. So just back to the topic I will talk today. The congenital cervical scoliosis, CCS, is a deformity caused by the abnormal bony structures of the cervical spine leading to the coronal plane imbalance. So the CCS is an exceptionally rare condition that significantly impacts both appearance and also the psychological well-being of the patient, especially most of the patient is children. So you can see the majority of patients initially sought medical attention due to the cosmetic problems with the common clinical manifestation, including the neck tilt, also the shoulder imbalance, and so on. And the head and neck tilt in congenital cervical scoliosis may be noticed at the early as birth. So these deformities often have significant psychological impact on the children. Sometimes the child was told by his or her classmates that you are look different from us, so that come to our clinic. But as illustrated, the vertebral deformities are highly complex, involving not only the upper and lower cervical spine, but often extending to the thoracolumbar. The complex morphology and the challenging anatomical location of these deformities make our surgical correction particularly difficult. So in the past 15 years, our team, led by Professor Sun, we have treated more than 100 patients with varying types of congenital cervical deformities, each managed with individualized surgical strategies tailored to specific pathological patterns. This comprehensive surgical data set facilitates to establish and dedicate cohort, and we try to develop a classification of this very rare but complicated deformity, and also we will try to provide a structure framework for the understanding of the deformity and to guide the surgical planning. Cervical scoliosis primarily results from two key mechanisms. One is the failure of formation, and the other is the failure of segmentation. So failure of segmentation can be further classified based on the extent of fusion into two main types of block vertebrae and unilateral unsegmented bar, where segmentation fails on one side, often resulting in the progressive angular deformity. So a well-known and recognized segmentation failure is the Klippel-Feil syndrome, and after the we can see we all know about the KFS. So the other type of the failure of the failure of formation, we can just divide it into wide vertebra, hemi vertebra, and butterfly vertebra. Oh, I'm sorry. So with that, okay. So this table illustrates the distribution of fusion segment across different cervical levels. So in our retrospective cohort of 103 CCS patient, a total of 225 treated segments were identified. The most frequently fused level was C2 to C3, and which is consistent with the private published literature. So as shown in the left image, you can see the typical three types of lower cervical spine deformities about the formation: the wide vertebra, butterfly vertebra, and the hemi vertebra. The table on the right here, you can see our data about the 103 patient with congenital cervical scoliosis, a total of 94 wide vertebra and 66 butterfly vertebra, and 32 hemi vertebra are identified. So in response to these complex deformities, which are often accompanied by failure of segmentation, Professor Sun pioneered the concave side distraction technique in 2015. So convex side resection and concave side distraction restore we can all restore the coronal balance through the two distinct biomechanical principles. So which the resect of the convex is the peak cut. You just cut the peak, and the concave distraction is the fill the valley. That's the two different mechanisms, and we try to make a summary of our 103 retrospectively cases that point out our classification from PUTH. That the type 1 is based the single responsible vertebra. That's based on the concept of the responsible unit. So type 1 is a single responsible vertebra that is primarily characterized by a formation failure. For example, a single hemivertebra or wedge vertebra or butterfly vertebra. And type 2 is the single responsible vertebral complex that may categorize by either a combination of formation failure or segmentation failure, or a pre-segmentation failure alone, for example, the block vertebrae or partially segmented bars. And the type 3 means the multiple responsible unit, which may consist of either responsible vertebrae or responsible complexes contributing jointly to the cervical deformity. And the type 1 refers to cases of congenital cervical scoliosis caused by a single responsible vertebra, such as showed here. Right? Yeah, here is an example. So this is a 6-year-old boy presented with marked torticollis, and you can show the shoulder imbalance from this young boy. The CT imaging revealed a fully segmented hemivertebra at the left side of C4, identified as the responsible vertebra. So this young boy underwent C4 hemivertebral resection. So we can see the structural cup angle improved from 31.6 to 77 postoperatively, and the patient appearance shows significantly improvement. And there are another case of our classification of type 1. There is a 9-year-old girl with a 9-year-old history of torticollis. The CT showed a fully segmented hemivertebra at the right side of C5 and the C2-3 block vertebra. So the responsible vertebra was C5. So the child underwent C4 to C6 distraction. And we can also got a very good structural comp angle correction from 35.4 preoperatively to 4.9 postoperatively. And the third case showed about the type 1 classification. We can see a 7-year-old boy with hypoplasia of the left C1 lateral mass. So we just gave the patient C0 to C2 distraction, and we use an individualized 3D pointed planning a spacer to reconstruct the structure. So the structural cup angle corrected from 25.9 preoperatively to 3.6 degree post-op. So we can use that. The 3D planning was very useful for us to individualize the requirement of our patient. So this is another case showed the type 1. This is an 8-year-old girl with a 6-year history of the neck-tooth. And we can see the responsible vertebra was C7. It's a hemivertebra, so we give the patient is C6 to T1 distraction surgery, and we used also the 3D point spacer to reconstruct the alignment in the coronal plane. So the cup angle showed very good clinical result. So the type 2 means, classification type 2 means a relatively complex structural deformity, which means characterized by the scoliosis caused by a vertebral complex rather than a single formed vertebra. So the complex is defined as at least 2 adjacent vertebrae with segmentation failure, forming a structural unit in which the cup angle between the superior end plate of the uppermost vertebra and the inferior end plate of the lowermost vertebra exceeds 10 degrees. And based on the extent of fusion within the segmentation failure, the type 2 can be further classified into 2 subtypes. The type A means complete segmentation failure, and subtype B means incomplete segmentation failure with residual intervertebral spaces. You can find us in residual intervertebral spaces within the segmentation failure region. So this subgroup classification allows for more precise surgical decision making, which means enable surgeons to tailor their approach based on the specific deformity pattern. So optimizing correction while preserving cervical mobility wherever possible. So this is a case show that the classification of type 2A. It's a 11 years old girl with 11-year history of head tilt, which has worsened over the past 2 years. So the CT showed a complete anterior intervertebral fusion from C1 to C4, along with the C4 hemivertebra. So the responsible complex is the C1 to C4, the formation failure and the segmentation failure. So the surgery we choose for the patient is a C3 to C5 distraction and showed a very good correction effect. And the number 2 case of type 2A is a 9-year-old boy. The CT of the boy showed a butterfly vertebra at C3 and complete fusion from C2 to C4. So the responsible complex is the C2 to C4 complex, and we just distract the C4-5 level and got a very good clinical outcome. And the other case of the classification type 2A is a 26-year-old male, present a long history of the torticollis. So the responsible of this patient is the C2 to C4 complex. So we just distract the C4-5 level and also correct the deformity. So there is another case show the type 2B. It's a 7-year-old boy. So the responsible is T2 to C4, but you can see there's residual disc space within the C3 to C4. So we just distract the deformity within the responsible complex region. So we just distract from the C3 to C4 level and still got very good correction effect from the 18.6 pre-op to the 2.1 degree post-op. So we can just use a navigation system in the recent years that we can intraoperatively to guide the surgeon accurately put the pedicle screw and find the disc space. There are another case of type 2B. It's a 10-year-old boy. The CT image revealed a C2 to 5 block vertebra and incomplete fusion between C5 and C6. So there is a responsible region from the C2 to C6. So we just within the responsible region just distract the residual disc space from C5 to C6 and got a very good clinical outcome. And as for the classification type 3, that means multiple responsible unit. So this type involves multiple deformity driving unit, which may consist of the responsible vertebra or responsible complex. They can also divide it into 2 subtypes. The type 3A means the multiple units with the same direction of the scoliosis curvature. And type 3B means that the direction is opposite directions of the main scoliosis curvature. So you can see this case is a 7-year-old boy. The CT revealed a C7 hemivertebra and incomplete fusion between C2 to C6. So you can see the responsible unit is combined with the C2 to C6 incomplete fusion, also the hemivertebra of C7. So the surgery, but the curvature is in the same direction. So the surgery we just to distract at the level of C4 to C6 and C6 to C7, and got a very good carbuncle correction in both correction region. there are another case of type 3A. It's a 9-year girl. The responsible unit was C1 and C5, and also the C2 to C4. Yes. And we gave the patient C0 to C2, C4 to C6, and C6 to C7. On the right side, distract these 3 parts. So the 3 deformity unit exhibit the same direction as the curvature, and you can see the very good correction effect after the operation. And there's another case of type 3A, an 8-year-old boy. The responsible unit is the hemivertebra of C7 and also the unsegmented region from C2 to C4. So we also gave the patient C0 to C2 and the C4 to C5 distraction. So also got a very good clinical outcome. And as for the type 3B, which means the curvature of the responsible unit is opposite to the main scoliosis curvature. So this 13-year-old boy showed the responsible unit is C3 and C2. So just in the different directions. So we just from the left C2 to C4 distraction and the T1 to T3 distraction on the right side, and also create a very good coronal alignment after the surgery. And this is another one. So the 11-year-old girl showed a responsible unit from C2 to C3 and the C7 to T1. So we distract just from the different directions on the left side from the C3 to C4, and on the right side C7 to T1 to distract the concave side, and got a very good clinical outcome. There another case of 10-year-old girl showed the responsible unit that is C2 to C3 and also the hemivertebra as a C7. So we just distract these 2 regions on the both side and correct the deformity. So our classification and treatment framework, so make a summary, is built upon 3 key dimensions. That means number 1 is responsible unit. Responsible unit-based classification, which includes responsible vertebra. It's an isolated, malformed vertebra directly, and also causing the deformity. And also the number 2 is a responsible vertebral complex. That is structural units formed by multiple malformed vertebrae acting together. And then the number 3 is the deformity pathogenesis-based classification that may characterize into formation failure, segmentation failure, or the both. So the surgical approach strategy, which means we can choose our surgery from the convex to resect the problem, or we can distract on the concave side. So despite the recent advances, several critical scientific questions remain unsolved. That means the long-term efficacy of corrective surgery of CCI is still unknown, and there is a lack of comprehensive and standardized evaluation system for this condition. And also the etiology and the pathogenesis of CCI remain poorly understood. So this is our work. It's a single center unbispective cohort study spanning over 20 years, involving patients diagnosed with CCS who underwent surgical treatment at our hospital. So in this prospective cohort, the data will be collected preoperatively and perioperatively, including baseline demographics, radiographic parameters, psychological scores, and multi-system comorbidities and surgical details, and biospecimens. And you can see the primary objective of our study is to evaluate the clinical utility of our PUTH classification in guiding the surgical decision-making for CCS, and also some secondary objectives. And this study incorporate a comprehensive and standardized methodology, including both objective and patient-reported outcomes with mid to long-term follow-up, so allowing multidimensional evaluation of the surgical safety and effectiveness and supporting future nested research. In addition, the prospective cohort include preoperative biospecimen collection, enabling explanatory analysis of genetic mutations and pathogenetic mechanisms. So we believe that the establishment of the bidirectional cohort will enable us to address a range of critical scientific questions related to CCS and help to fill the global knowledge gap in the study of the cervical spine deformities. And the retrospective cohort include 70 patients who underwent the surgical treatment for CCS from our hospital between November 1, 2009 to 20 October 2024. So this cohort is primarily used to summarize the historical surgical outcomes, establish a deformity classification system, and identify potential prognostic factors. The prospective cohort will include 80 patients approximately underwent surgery between 20 October 2024 and August 1, 2029. So this standardized clinical data and biological samples will be prospectively collected. So this cohort aim to enable structured follow-up, obtain high-quality subjective and objective outcomes, explore mechanistic insight and validated findings from the retrospective analysis. So this is our flow chart about prospective cohort. Patient in this cohort will undergo scheduled follow-up from the time point before the surgery and also at the hospital discharge and also at the 3, 6, 12, 24, and 16 months post-op. So the retrospective cohort follow-up time point are determined based on available clinical documentation and imaging record. So most of the patients have records for the pre-op evaluation and post-op hospitalization period and at least one documented post-operative follow-up. So most recent available follow-up visits ranging from 2 to 10 years. And in general, to summarize my presentation today, from the numerous scientific questions remain unsolved. So we try to understand an urgent need to fulfill the high-quality, large-scale cohort study to enable the comprehensive understanding and validation to this rare condition. So we just upon our cohort, we try to propose our classification for this rare disease, and this system to categorize the patient on vertebral morphological anomalies and introduce a novel concept of the responsible unit. So by defining the responsible vertebra and the responsible complex, the classification provides a framework for the tailored surgical planning, and we can choose both the convex resection and also the concave distraction for the surgical treatment of this kind of patient. And also, we have to say there's a lot of questions that need to answer. So we just try to communicate with all the faculties here and all over the world, try to have the further work on this subject, and we try to give the continue without our cohort. And thank you very much for your attention. Thank you.
Jane?
Again, fantastic talk. It's amazing that you'll have the biggest cohort in the world. It's pretty impressive. So the question is, these are really complex deformities. They progress rapidly throughout childhood and adolescence. So when do you, I have two questions for you. So the first one is, when do you indicate the operation, I guess, and then when do you do the operation? So indication for the operation versus doing the operation are two different things. And then that's the first question. And then the second question is how, like, do you have any like 10-year follow-up on this? Like, what do the necks look like in these kids that are fused? Like, what's the, how do they look when you fuse somebody who's 8 years old? How do they look when they're 18?
Okay, thank you for the questions. So number one, as I mentioned during my presentation, a lot of the patient, the child was found the deformity by their parents at the early birth. But I think the little very youngest our patient is only 1 to 2 months after their birth. The parent found there's a neck tooth of their child. So, but the bony structure is not fulfill the requirement of the surgical treatment. So usually we may wait for the child until 5 years old. And of course, it's very individually. We have to give the child a CT scan to measure from the CT scan about the diameter of the pedicle and also the length and the depth of the vertebral body to find whether we can just operate on this child. That's the question number one. And the question number two is that is found. The first question is when we found the patient at the first. And after we just operate on this patient, we have to follow up for a long time because we always operate before they're grown up. So during more than 10, even 20 years, we have to say what happened. So the longest follow-up in our cohort is about 17 patients over 10 years follow-up till now, till this today. So we just have these more than 10 years follow-up, the appearance, the correction rate, and also the grown-up for in every system of this child and become to the adult. It's normal. So that's very encouraging result for us that is can be tested for more than 10 years. Thank you.
I also see, and I found that a significant minority of them have a syrinx associated as well. In your experience, how do you think through managing syrinx? Do you ever do shunting and the correction in the same setting, or do you stage it? And if so, how far apart do you stage it?
Yeah, we have a multidisciplinary team, so we just make a consult before the surgery, and we found a lot of anomalies beyond musculoskeletal system. For example, the neural system and also a reproductive system and so on. So we just asked all the experts before the surgery. We just cracked the deformity, and we may just follow this child in different teams. So they may get, the treatment by the specialist.
Feifei, great talk. I have a question for you. So the distraction of the concavity is, really smart idea where, you probably have a lot less bone blood loss compared to resection of the vertebral body or hemivertebra. How hard is the distraction? In more rigid cases, are there tricks and tips that you use to achieve the correction? That's the first question. Two is that how often do you see vertebral artery anomaly associated with, and how do you, safely manage that throughout the case?
Yeah. Okay. Thank you, Tan. I think the first question is at the difficulty we can or how rigid it before we just cracked it during or before the surgery. I think there's another presentation I think Professor Sun will give tomorrow, and I will give the day after tomorrow. So most of the cases is not very rigid, is flexible. And it depends on the region of the, the deformity from the cranial cervical junction, and if the also is very different from the region just across the cervical thoracic region. So that may be the reason number one. And some of the patient we need to distract before the surgery. And I think the most important is the release about the structure during the surgery, about the capsule of the antevertebral joint and about the facet joint. And mostly we do not need a lot of osteotomy to try to make the space that we can distract the concave side. That number one. And number two, of course, every patient, we should give the patient CT angiography of the vertebral artery before the surgery. And we found a lot of anomalies in about the vertebral artery. But I think that's why we just love to choose the concave side distraction, because during this procedure, you always do not need to expose the vertebral artery. Besides, the vertebral artery have some anomalies that make you difficult to release the structures that I mentioned before. That distract procedure, you do not worry about the vertebral artery. Yeah, we always do front, back, front. It's for the distraction concave distraction method. That's right. Okay, thank you so much.